Awesome. So it looks like we've actually managed to go ahead and get this procedure done now, which is a relief and clearly great news for the patient and us. But the story isn't over yet, because that patient needs to safely arrive at hospital or be discharged from your ED, whether that is to a ward or to their own home. Now, James earlier did a pretty good job of covering those AA-GBI monitoring standards, and in the post-sedation phase, we are going to be continuing to monitor all of those. So just to recap what that means that the patient needs to stay on ECG monitoring, they need to have a non-invasive blood pressure cuff on and set to a reasonable time frame. They need to continue on oxygen saturations monitoring and, of course, end-tidal CO2. Now, as we previously mentioned, this is something that we're going to be using for all of our sedations. So the next thing that we need to talk about then is how long are we going to monitor these patients for? Well, the guidance from the colleges is pretty vague on this, actually, particularly if you're trying to establish a timeline for how long they are likely to still need any nursing or medical input. And that can be quite difficult in the ED if it's busy. So I guess that one of the things that might guide you from the off is the agent that you have available to you, so the drug that you have available to you, and specifically the pharmacokinetics of that drug. Some knowledge around this can really help, so thinking specifically about the drugs that Simon discussed. Well, propofol, so this generally has a duration of 1 to 3 minutes, so it's really quick onset and offset. However, you need to be a little bit careful as repeated doses can prolong that recovery phase. So propofol, pretty short duration. Midazolam, now that has a maximum effect that occurs around about 10 minutes, but the elimination half-life is in the region of 1.5 to 2.5 hours, so quite a lot longer than that propofol. Now, ketamine, on the other hand, so that has a duration of around about 5 to 15 minutes if you give it IV, or 15 to 30 minutes if you give an IM. But you should be aware that there might be some factors that are outside your control, and the distribution and metabolism of those drugs can change from patient to patient. So thinking specifically about those with either liver or kidney failure. So these figures that I've just mentioned are really a range, and they will fall somewhere around that, hopefully. Okay, so now we've got a rough idea of how long we're expecting them to be with you, a rough idea, I must say, but how are we going to know when they're ready to go? And this is where the guidance is fairly straightforward on this. So there are 4 criteria that need to be met. So the patient needs to have returned to their baseline level of consciousness. And this tends to be, in my experience, the thing that takes the longest to get back to normal, and it can be quite variable. The second thing is that the vital signs are within normal limits for that patient. So you don't need a news score of 0 or whichever early warning score you do use if it wouldn't be that low on any other day that you were doing it in that patient. Now, their respiratory status as a third point needs to be absolutely perfect. So we can't be discharging a patient with a compromised respiratory status. And finally, the last thing is that pain and discomfort should have been addressed. And typically, you want to make sure you are giving simple analgesics and they're effective. So I'm really not a massive fan of giving analgesia just so you can get someone home, but you need to make sure that the analgesics that you are giving are effective and will work for them. So there's 4 criteria there. So the patient needs to have returned to their baseline level of consciousness. Their vital signs need to be within the normal limits for them. Their respiratory status needs to be perfect, and their pain and discomfort need to be addressed. Now, if they have met all of those criteria, then they should be discharged. But importantly, it needs to be to the care of a suitable third party, i.e. they can't just drive themselves home, and they need to have someone with them who is responsible. Now, the final part of this, just to make sure it is as safe as possible, is to offer some verbal and written advice. And the key things to inform the patient and relative are that judgment might be impaired for 24 hours, and for that reason, don't drive a vehicle, don't drink alcohol, don't sign any important documents in that period, don't operate any machinery or appliances, and don't care for any dependent adults or children without help. But thinking about things they should do, well, for that 24-hour period, they should be resting as much as possible, they should be drinking plenty of fluids, and they should be eating what they describe as a light diet in the guidelines. So after they've got that written advice, which we have at the back of our pro formas locally, and there is also some available online, they are free to go and free to be discharged.
All right, nice one. Thanks ever so much, Rob. Really nice little summary there of post-sedation monitoring and discharge criteria. Sounds pretty challenging, actually, in a busy emergency department to try and work out how long you're going to have to look after these patients, even though actually the ultimate discharge criteria is pretty clear. So I can see that would be hard work for you.
It's something we're used to, James, so don't worry about it too much, mate. But yeah, it can be quite a challenge, especially when people are asking you, when's the next bed going to be available? When's the next resus cubicle going to be available? It can be a little bit, the answers can be a little bit short from time to time when you ask those questions.
I think that's understandable. So listen, a couple of things kind of popped into my head while you were talking there. So one thing we didn't mention, or you didn't mention, was the idea of any sort of referrals beyond that discharge. So are there any situations in which you need to let other specialties know about the fact you've done this sedation? And do you need to book any appointments for this patient in the long run?
Yeah, so I mean, definitely is a short answer, but it's almost dependent on what that patient's come in with and what you've done the procedural sedation for in the first place. Clearly, as we've already talked about, musculoskeletal injuries will be the vast majority of these patients that you'll be seeing. And so, forward referral to either inpatient orthopedics, depending on what their level of injury was, or, an outpatient follow-up. Commonly, we'll refer to fracture clinic, which will be, within a few days or up to a week in some cases, depending on what it is. You could consider specialist clinics as well. So I guess, if thinking about if you've got any specialist shoulder clinics or anything like that, knee clinics, I guess, if you got particularly painful, patella dislocation or something like that. But in most cases, it will be a case of getting them off home. I think it's a little bit more challenging if the patient does need to come into hospital, but essentially it's whatever is their primary complaint will be the referring specialty. So if it was, if the patient needed a DC cardioversion, then it's going to be, cardiology or the acute medics that take the referral. But they won't tend to leave that department until they have reached that, if you like, those 4 criteria that we previously talked about. So they have to be awake and things like that. And until that happens, the hospitals that I work in, they're not set up to admit them to anywhere else. Like you wouldn't admit them to, HDU or level 2 care just so that they could, sleep off their sedation. They'd stay with you in resus until they were ready to go to a ward area, mate.
Yeah, nice. Fair enough. It's interesting from our sort of pre-hospital perspective, because I guess, our referral area is you. So, we do our sedation, take them to hospital and then, wash our hands of them. So it's interesting to hear what happens further down the line. So something else that I found interesting was this idea of the suitable third party. You made the comment that they need to be discharged into the care of a suitable third party. Now, I'm pretty certain I understand what you mean about that, but shall we be a little bit clearer about exactly what that means? Who is responsible?
Well, I would class you as responsible, James. I would class Simon as irresponsible. So that's a good example of the sort of the benchmark that I'm using there. But I think, it's this idea that what you just need to be a little bit aware of and make sure that you don't get caught out by is these patients that are going home and what they're going home to. So, you can get patients that you've had to give some procedural sedation to reduce painful injuries that have had, quite a large amount of alcohol on the odd occasion. And, when people drink quite a large amount of alcohol, most people will tend to drink it with friends or with acquaintances. And, a heavily intoxicated mate who's with them is not a responsible adult that's going to be able to care for them overnight. And therefore, you don't want to be discharging them with those. It's really just making sure that there is someone that's relatively responsible, is pristine in terms of their intoxication status, as in they're not intoxicated, but also that they're able to summon help. If in doubt, I guess what I'm trying to say here is you want to make sure that they are safe for that discharge and there is going to be someone with them responsible for 24 hours, which is what the college guidance says on it. So, someone responsible, although that level of responsibility might change depending on who that person is. But actually, I guess that does just make me think. So, in terms of the patients that you're sedating, so if you're doing procedural sedation pre-hospital as part of, your critical care team, I take it you're bringing all of those to hospital. You're not going to be discharging them at all, are you? Would that be fair to say?
Yeah, no, fair question, actually. So I guess there's 2 elements to that question, isn't there? So Are we bringing them all to hospital? Yes, we are. And I think really for many of the reasons that we've discussed throughout this conference, but also the ones we've just discussed just now, which is that patients aren't, immediately ready for discharge on scene. They may need to be referred to other specialties and so on. So absolutely, the need is still there for them to come to ED. But interestingly, up until just recently, certainly in the Southwest, the critical care team or whoever has provided the sedation has been the ones that have needed to transport the patient to hospital. But we've actually just had some new guidance published to us from the Southwest Ambulance Service, which is surrounding ketamine and ketamine alone. And they're saying, and I think very sensibly actually, that if the patient's received a ketamine sedation with no other adjuncts, so we haven't given them any fentanyl, morphine, midazolam, they've just had ketamine, then actually the patient can be handed over to a paramedic or nurse crew. It just can't be a newly qualified paramedic. There's a few criteria, obviously, that need to be met before we can do that. And again, all really sensible. So the patient has to have fully recovered from the effects of the ketamine. They need to have no ongoing requirement for ketamine and no potential requirement for any post-ketamine anxiolytic therapy. So I guess there we're thinking about that horrible kind of emergence phenomena. So they've come out the other side, they're fully recovered, and they're not going to require any anxiolytic therapy. The patient obviously also needs to have no other requirement for enhanced or critical care if we're handing them over to a non-specialist paramedic crew. And obviously linked to that, the patient needs to be extremely unlikely to deteriorate in your clinical opinion, and the lead clinician on the conveying resource is happy to take over responsibility for caring for that patient. So yes, all of our patients are going to come to hospital, but you might find that they're not necessarily coming in with the team that did the sedation in your area. I guess it depends on local guidance.
That's interesting, and that's good. I think that's just a really good pragmatic way of moving forward, isn't it? You're quite right. I mean, the incidence of problems after that patient has recovered fully are really, really, really low, aren't they? And you're quite right. You don't want to tie up those finite resources just for a patient who is essentially coming to hospital to have some further management done, but they've already had that sedation done pre-hospitally. So, yeah, I think that's a great bit of guidance, really.